Great. Thank you, everyone. It's great to see this full room of people. And it's a real pleasure to open up the 2022-2023 Population Health Spotlight Series. The theme for this year's series is Public Health at a Crossroads, which honestly sounds a little bit like we're going to sell our soul to the devil. But it also raises some interesting questions about which direction we're headed in and which directions we can head in and really rebound from the past 2 years of challenges, missteps, heroic efforts, and ongoing threats to health and health inequities. When this theme was first announced, I immediately thought of Gregg Gonsalves as someone to invite to Drexel. Firstly, because Gregg has opinions. And because over the 20 or so years I've known him, I've found him to be an inspiration. Gregg is an epidemiologist and a global health advocate with a long history of community activism, working with domestic and international organizations such as ACT UP, the Treatment Action Group, the International Treatment Preparedness Coalition, and the AIDS and Rights Alliance for Southern Africa. In each of these roles, Gregg was not just in the streets, but also in the conference rooms, working with epidemiologists and researchers to push for greater understanding of the barriers to addressing HIV and the need to accelerate the response. At Yale University, after finishing his PhD in epidemiology and joining the faculty, Gregg co-founded the Global Health Justice Partnership, an interdisciplinary initiative between the schools of law and public health, focused on human rights and social justice perspectives in public health and legal research, practice, and teaching. The partnership has worked with colleagues in South Africa to document the failure of mining companies, has also worked in Brazil to investigate the role of the war on drugs and high incarceration rates on the community burden of TB, and in the US on increasing the availability of hepatitis C treatment in US prisons. Has been outspoken on the need to ensure equitable access to vaccines worldwide, as well as medicines, to take on intellectual property rights, and to emphasize human rights related to gender and sexuality. Gregg's research combines quantitative approaches and operations research modeling, seeking to improve policies that impact access, uptake, and retention and care for people living with HIV and in need of substance use treatment. Please join me in giving Gregg a warm welcome for his talk, Outbreaks, Overdoses, and the Failure of Political Will in the United States.
Wow, such a big crowd. Saying this is maybe my second in-person seminar in 2.5 years, so I'm happy to be at Drexel. So I'm going to talk to you about outbreaks of HIV among people who use drugs and the failure of political will in the United States. Dealing with overdose on top of that is a little bit too much to bear, so I've truncated the story, but what goes for this goes for everything else. So I want to talk to you about a case study in public health decision making. And it's the story of the outbreak of HIV in Scott County about 5-6 years ago. And why is it important? Because it involved major political figures, some of which you may recognize here. This man becomes a very important person in the story, and you'll find out about him later. It involves a vulnerable and criminalized risk population, a stigmatized health outcome, right? Political opposition to proven interventions. It's a mix of federal and local responsibilities and efforts that were that bore down on this problem. And there's competing narratives, importantly, about what public health decision makers should have done. And the story is important because it will happen again. So hold on to that. So let's talk about health in Scott County, Indiana. We want to talk about policy failures and failures of political will. We start with this. Scott County, down here, is 92nd among 92 counties in Indiana in health outcomes. The excessive premature deaths compared to the rest of the state and to the US, and it has the second highest average adjusted prescription drug overdose mortality rate in 2002 to 2013. So keep that in your head, right? The only HIV testing center closed in early 2013. This is just a recapitulation of some of those health figures in terms of premature death, quality of life, health behaviors. The point is that Scott County, Indiana, is at the bottom of the barrel in terms of health outcomes in the state. In 2011, Planned Parenthood ran 5 rural health clinics in Indiana, were incredibly important in offering HIV testing, prevention, and preventive counseling for better health, right? They were not just about reproductive health, they were about preventive health more broadly. In 2013, the Indiana state legislature defunded Planned Parenthood, despite court objections to doing so.
I'm trying to keep oriented a little bit towards the
Of that.
Yeah.
Okay. Also, let's look at painkiller use in Indiana. Again, some of the highest painkiller use in the country compared to other states, and 21% of everything in prescription drugs, it's Oxycontin, Percocet, Vicodin, etc., without a doctor's prescription. So there's a lot of prescription overdose and painkiller use happening in the state. This is all prologue, right? Again, you're starting to see a pattern here, right? Unintentional drug poisonings from 1999 to 2009, over a decade, an explosion in unintentional poisonings. Many of these we can use as a proxy for drug overdose. And then prescription drug use among young people. Again, some of the highest rates of prescription drug use among young people in Scott County. And again, compared to the US, Indiana overtakes the American average as well. Okay, so this is all sort of the socioeconomic health systems context of Indiana and Scott County before the outbreak of HIV. Now let's talk about OPANA, right? It was reformulated in 2010 because it was thought to be a better way to keep from being misused. The prescription drug use that we talked about previously. But it was a decision that had unintended consequences because it could quickly replace Oxycontin, but it could also be snorted and injected. And so it is a higher morphine equivalent dose than Oxycontin and morphine. So it's a perfect drug for misuse in terms of its ability to be crushed, injected, and giving you a bigger bang for the buck than the previous drugs, Oxycontin and morphine. Again, I may be harping on sort of the prologue here, but look at what happens to hepatitis C in America between 2006 and 2012. Indiana becomes a major center of emerging HCV infections among young urban, non-urban persons who inject drugs in 2006 and 2012. In 2011, in these other counties, Henry, Dearborn, Decatur, Tippecanoe, there were these HCV outbreaks in 2010, 2011. Not in Scott County, but reasonably nearby to give you a sense that something is awry. Gaps in treatment capacity. We can treat opioid use disorder, but the rate of opioid dependence versus the availability of medicines for opioid use disorder. Indiana has some of the highest need, but the lowest availability of treatment for OUDs. So this is all to say to you that the potential for outbreaks of blood-borne infections in Indiana among people who inject drugs was apparent for at least 10 years before the Scott County cluster was detected in 2014. 10 years, right? Rise in drug poisonings, the high number of painkiller prescriptions, the high rates of prescription drug use among young people, the emergence of hepatitis C outbreaks among young people who inject drugs, large gaps in opioid agonist treatment capacity compared to other states. So a perfect storm is brewing, right? And what happens? 2014, 2015, we're going to talk about now. We have an outbreak of HIV in Scott County, Indiana, in a small town called Austin. And so as of March 2nd, 2017, after the investigation was done and the interventions had been rolled out into the county and into the city, into this little town, there had been 215 HIV infections diagnosed. Now, Scott County alone had a prevalence of 1%. Austin, which was home for 80% of the cases, had a prevalence of 4.6%. The adult prevalence in the United States of HIV is 0.39%. So this is the largest It's one of the largest outbreaks of HIV in America. Think of that prevalence is not seen in this country, right? But it was seen in this little tiny town in Indiana. Okay, so what happened there? So the first cases show up in November 18th in 2014. The Indiana State Health Department begins an investigation, and in January 2015, and 17 cases are identified. And the MMWR talks about this initial investigation. Okay, more details about the story. March 23rd, a team of CDC investigators arrives. Later in March, Indiana declares a public health emergency. March 13th, an HIV clinic testing opened. What happened in 2013? Did something close? All the HIV testing clinics closed. April 4th, Governor Mike Pence announces Executive Order 1505, saying there's a public health emergency and authorizing Scott County to set up a needle exchange program. May 5th, a few weeks later, he signs a bill to allow Indiana counties to establish syringe exchange programs in the event of an HIV or HCV outbreak. But the same day, he signs a bill upgrading possession of a syringe with intent to commit a controlled substance offense from misdemeanor to a felony. Gives with one hand and takes away with the other. Front page of the New York Times, or nearly so. This was framed as a story of public health, deliberation, and decision making. It talks about Mike Pence's response to HIV outbreak, prayer than a change of heart. It talks about how the sheriff convinced him that this is the thing to do, and he allows the initiation of a syringe exchange program in Scott County, Indiana. But this is a very sort of like elaborate story about a man's change of heart, and it doesn't really talk to you about the sort of policy figures that we just articulated for the past 10, 15 minutes that led to this crisis in the state. This is the epi curve, right? In the paper by Peters in the New England Journal, from initial diagnosis, when the emergency was declared, and how many syringes got rolled out into the streets afterwards. So this is a piece of information that we'll use in this analysis to help you think about what should have been done in terms of dealing with this outbreak. So this is a big deal. From JAMA to the New England Journal of Medicine, there was a huge back and forth about what the hell happened. It's 2014. We've known about HIV. We've known about the risk of injecting drug use and bloodborne infections. What the hell happened, right? There was casting of blame on each side. Could we headed this off at the past? Could we have stopped this in its tracks? Or were we helpless in the face of some unknown emergence of a pathogen in this small corner of the state? So there are counterfactual claims. Campbell and colleagues said, look, if there had been a syringe exchange program in place prior to the recognition of the outbreak, the explosive phase of the outbreak may have been blunted. Joey Rich and his colleagues at Brown said, what happened in Indiana was predictable and avoidable. Even NIDA director Nora Volkow, who generally is a federal employee, doesn't speak plainly about these things, said this epidemic should not have happened. We've known for many years that providing free needles to injecting drug users is a strategy that prevents the spread of HIV in a community. And a needle exchange program to affect county in Scott County in early April, but this was far too late to prevent the outbreak. So this is all happening 2014, 2015, 2016, trying to make sense of what happened in Scott County, Indiana. Remember I said, keep an eye on this person. In that early picture, this is Jerome Adams. He was the health commissioner of the state of Indiana, became our Surgeon General under President Trump. And he wrote back blisteringly in the New England Journal saying, some commentators have never commented on world health policy, suggests the outbreak could have been prevented if needle exchange programs had been legal. My colleagues and I will never know the HIV infection remains rampant in many urban areas that are needle exchange programs. We don't know. Basically says we couldn't have known this was going to happen. We couldn't have known this was going to work. Needle exchange programs operate in many cities around the world, around the country, and around the world, and they haven't stopped HIV infection in their tracks. So basically, we said, get out of my face. We did what we could. You people from out of Indiana know nothing about what you're talking about. Right? It was not any sort of admission of culpability or trying to sort of think about what went wrong on the ground there. So my colleague Forrest Crawford, who's in the Department of Biostatistics, And I decided to say, like, you know, there are these competing questions in public health. Could they have done more? Could they have done anything? Could they have stopped this in the tracks, or were we just simply helpless to stop this outbreak in Scott County? So we had two questions we wanted to ask, right? Was the public health response late? What would have happened if the response had been initiated earlier? And the answer speaks to the dynamics of the actual outbreak and the response and provides guidance for future outbreaks. That was the goal of our epidemiological study or project here. You know, I've given you history, I've given you some sort of context about what had happened and what had happened in the year before this outbreak. But first, I wanted to answer two particular questions. So what did we use for data? Remember this curve? We tried to get data from the CDC and the state or the Indiana Department of Health, and we were denied. We said, can we have outbreak investigation data, aggregated figures? We don't need personal detail. They said no. We went to the law school at Yale and said, will you file a freedom of information request for us? But the federal and state level, we were denied. So what do we do now? We were undeterred, right? So we knew we had weekly case data on the outbreak from Petersville, right? Now, this was interesting. Campbell did a paper, which was basically a molecular epidemiology dissection of the outbreak. But they had this one curve in there that recapitulates sort of what the incidence of the outbreak looked like. It's not in the original New England Journal paper, but CDC in this case had done these antibody avidity assays that could tell you how old each infection was. And they created an incidence curve. This is what the curve looked like in the New England Journal article of those prevalent cases that you see in the first graph that I showed you. But this curve shows up in this paper in JID by Campbell et al. And we realized this gives us more information. And we said to them, can we have your data? They said no. They said, we'd love to give it to you, but you know what you could do is extract this curve using just a graphic extraction app and recreate it yourself, right? So we used the published images, we digitized this, and we created the curve for ourselves. And I'm not going to say that we were egged on by the CDC scientists, because that would be wrong, but they did stop us from doing it. So we have two pieces of evidence now, right? We have an incidence curve and we have a diagnosed infection curve. The first question gets answered off the bat. Was the public health response late? Yes, right? This is just the raw data. Remember, here's the cumulative HIV incidence, and here are the diagnoses, right? Was it late? Boom, right? The diagnoses start years later from after this outbreak had started in Indiana. So the response was arguably late. It's incontrovertible. The data's there. It's raw data. You don't have to do any analysis. The second question becomes trickier, right? What would have happened if the response had been initiated earlier? And this is a little more complicated. So now we have to think about the dynamics of disease in the context of this outbreak. And we decided to use it, to do this in using a simple disease model, mathematical model, and we wanted it to be simple, analytically tractable, and easy to understand, and just to capture the essential drivers of the outbreak and the response. We didn't want to do an elaborate model that would take lots of leaps of faith to parameterize and drag values for our model into. We wanted to deal with the evidence we had at hand, put it into a simple epidemic model, and see if we could get some answers to our questions. For those of you who think about mathematical modeling of infectious disease, this is very sort of boilerplate. It's an SIR model, except we break up the infected compartment into undiagnosed and diagnosed. And these are the equations that talk about the transition from state to state in the SIR model, with the beta being the transmission rate per perceptible infected pair, gamma T, the diagnosis rate per HIV positive undiagnosed individual, rho, the removal rate of diagnosed individuals, and N, the population size of HIV. this is sort of classic SIR models, except with two compartments. Because what do we know? We know when people were diagnosed, and we know the general number, the number of people who were infected in the epidemic. We know when they were diagnosed, when they were infected. So we use this simple model to reconstruct the outbreak dynamics. The cumulative HIV diagnosis curve be DT, right? And the cumulative incidence curve be CT, right? We have these. These are just taking them from the data that we have. From the first infection data based on the CDC recency assay data, we can get a lower and an upper bound of our incidence curve. Remember that those red dots we extracted don't give you a line, they give you a spread of values which we can use to populate an upper and lower bound curve for the cumulative incidence curve. And the HIV infection, the number of diagnosed HIV infections at time t is the cumulative number of infections by time t minus the number of diagnosed infections, as you see here, right? And the number of susceptible individuals is n minus the number of incident infections at time t. And this way we can develop lower and upper bounds for the incidence curve and derive number of susceptibles from these equivalences. And you can go to our paper, which I'll list at the end, but these are just slightly tinkered with equations from an SAR model to reconstruct the diagnosis and permission rates using the data we have on diagnosed cases and incident cases in the lower and upper bounds, right? And I won't walk you through all of these in the interest of time, but I can talk to you afterwards about it, and the paper discussed it in more great detail. We had a parameterizer model. We had only a couple of unknowns in our model, our beta, our rho, and our n. We set the transmission rate basically using beta, the upper and lower bounds of beta divided in half, and then the rate of viral suppression for diagnosed individuals. We set rho at 6 weeks. We figured people would be cleared of virus and quote unquote recovered and unimportant in the context of epidemic transmission within 6 weeks. And we said, at least from CDC data and the estimates of the number of people involved in this outbreak was about 536. And again, we set it up to be simple, clear, and defensible. And Brian Williams is a mathematical modeler in South Africa, and he talked about fitting and projecting HIV epidemics, and talks about the essence of good modeling being about staying as close to the data as possible, right? Our incidence and diagnostic curves include as much biology as possible, what we know about the suppression of virus under antiviral therapy, the data from the field, right, from the diagnosis and incidence curve we have, and then to keep it simple. We really did not want to make a complex agent-based model, which might have been exquisitely adapted to recapitulate this epidemic and this outbreak in gory detail. We just wanted to reconstruct the compartments from publicly available data so that people couldn't say, well, where did you get that value from? Oh, you took that from a paper from 1936 or whatever. We wanted to say, you want to know the data? You can look in the MMWR, you look in the Journal of Infectious Disease, you can find all our data in the public record. We're not sort of estimating any of our parameter values except those that we use in the equations that are shown. It doesn't look so bad, right? The model projections and the raw data track with each other. I mean, yes, there's some width there in the model projections versus the raw data, but in general, they're going in the same sort of trajectory, even if there's a little bit of a spread for all of them. So we feel like the simple model gets pretty close to articulating what happened in Scott County during these years before an outbreak was discovered in 2014. Now we had to do something slightly tricky because we know when the first diagnoses are happening, right? They're happening in November 2014, and then you start testing people in January of the next year. We wanted to try to think if we could develop a way to develop a counterfactual diagnosis rate. And I won't talk about these equations, but to say we wanted to create a counterfactual outbreak dynamic, right? We wanted to take the exact same epidemic, right, that I showed you with those orange, purple, and gray curves, and then take the intervention and move it back in time. Right, so what would have happened if we had the first diagnosis, not in November 2014, but earlier in the course of the trajectory of that outbreak, right? So sliding it along. So all you're seeing in these equations is a way for us to sort of take the epidemic the way we formulated using an SIR model, and then take the initiation of the intervention, not in the real circumstance, but in several hypotheticals, which are earlier than actually the state did intervene. So you'll see, and you can play with this on your own, because they're just shiny out that you can look at. But we wanted to say, like, okay, so we've given you the exact same outbreak dynamics that happened from 2011 to 2015. We said, what happens if you started your intervention on January 1st? This is just diagnosis. This is just HIV testing. We didn't care about needles or methadone or buprenorphine. We said, if you just started testing in January 2013, what would have happened? And here are the real dynamics of the outbreak. And then there's a cumulative incidence, a cumulative HIV incidence in our model. And basically, we averted at least 127 of those infections, right? We've greatly blunted the outbreak in Scott County if we had started simply just testing earlier. What happened in 2013? The 5 Planned Parenthood clinics closed in rural Indiana, right? So it's conceivable that somewhere in here they could have started, they could have found the first cases of this emerging outbreak earlier, and it averted a large chunk of those that came later. We said, okay, let's pick another date. And so we said, let's look at 2011. But this becomes even more dramatic. We drop down to about 10 cases, right? We reverted about 183, 184 cases. If you had started testing in April 2011, now what happened in 2011 when we talked about the prologue to this outbreak? HCV. You start seeing HCV outbreaks around the state. And it wasn't lost to people in Indiana at the time. If you look at the state hepatitis planning council documents, they're screaming bloody murder. They're saying, there's something going on here. We need to get out there and do testing for HCV in other counties in the state. We also need to think about HIV, but fell on deaf ears. So there's an opportunity to intervene here and intervene here, which could have drastically blunted this epidemic, and in real terms, probably avoided the epidemic altogether if they started early on. If you do not believe us, you can go to the Shiny app, and the link will be at the end. But you can tweak our beta, our gamma, our rho, the number of people at the start of the pandemic to see what happens if you change the dynamics of the outbreak or change the time of intervention. And so this is just to give, again, this has been the idea that we want you to know where all our data comes from. Like, it's all publicly available data sets or things we've been able to infer from yanking stuff out of the plots in other papers. And then we said, if you want to see the guts of what's going on, here's a Shiny app. You can play with it and see what you think of how the outbreak might have developed under another set of circumstances. So we use publicly available data to reconstruct the trajectory of undiagnosed HIV positive individuals in Scott County, right? What I think is apparent from just the raw data in that early slide in our model is that the response measures mostly occurred after the peak in undiagnosed infections, right? A lot of stuff happens in 2011 up to the first case diagnosed in 2014 in November. And by the time they're ready to do needle exchange testing, treatment, you know, the outbreak is largely peaked and starting to rear itself. All we did, it's desperately simple. We use the epidemic model. It's just capturing the dynamics of the outbreak. We just look at what would happen in observed scale up in diagnosis that it happened earlier. If you just did test it earlier, what would have happened? And I think the take-home point is that earlier scale up of testing would have dramatically blunted the scale of the outbreak. Okay, so you know, this does not capture the complex dynamics of real-life HIV outbreak when people inject drugs. My friend and colleague Brendan Marshall at Brown does a subsequent paper after our paper that is an agent-based model that is incredibly elaborate to sort of reproduce the dynamics of the outbreak with perhaps a little bit more fidelity, but with a whole lot of other assumptions we didn't want to make. We assume the knowledge of andesites, the peak WID population, but we had really no idea how many people were at risk in Scott County. It could have been just people who injected drugs. It could have been people who injected drugs in their sexual partners or a broader group of people. We made some assumptions about what we thought was the at-risk population in Scott County, Indiana. We made some biological assumptions that people who were diagnosed as HIV positive, that people who were diagnosed as HIV positive could contribute to the. We said they didn't contribute to the transmission of HIV infection, but they were removed from the pool of infectious people at rate growth, right? So we basically said, once you're diagnosed at a certain rate, you're removed from the pool of infectious individuals. What's really important, people are like, why didn't you do this? We didn't model the effects of interventions such as education or syringe exchange programs to the transmission rate data. Why? Because we had no idea how many syringes were given out when, right? We wanted every piece of our model to be, we say, there's the data, there's the data, there's the data. We didn't have enough data to parameterize anything about the effects of education or syringe exchange because we didn't have any sense of its scope or effectiveness, and so we left it out. So the bottom line is that our work supports the claim that the HIV epidemic in Scott County might have been prevented or mitigated with an earlier response. But the important thing here is to think of what we did as a lower bound, right? This was just for scaling up HIV testing earlier, right? So this is the least that could have been done in the context of that outbreak. If you had used other kinds of interventions, such as syringe exchange, opioid agonist therapy, you could have prevented the outbreaks altogether. Chris Byer from Hopkins, now at Duke, wrote a piece called No More Scott Counties to accompany this article in the Lancet HIV. But this isn't the end of the story. And this is actually usually where I say thank you very much. Thank you for having me at Drexel. Goodbye. But we're going to talk a little more. What happens next? Well, around 2016, CDC puts this map up. So these are vulnerable counties and jurisdictions for outbreaks of bloodborne diseases in the United States. The pink ones are the highly vulnerable counties. You can already see that Scott County and the Indiana counties, which are the ones that had HIV outbreaks in 2011, are listed for scrutiny in the CDC map for 2016. Just let this soak in. Scott County happens in 2015. Miami. Several counties in West Virginia. Cincinnati, Ohio, and Northern Kentucky. North Seattle. Outbreaks of HIV when people use drugs. Lawrence, Massachusetts. Boston, Massachusetts, an ongoing outbreak of HIV. We did all this work to tell you about what could have been done, what should have been done in the context of the HIV outbreak of Scott County. And yet this is what we see. Not no more Scott counties, but 4, 5, 6, 7 new Scott counties. We work closely with a lot of these jurisdictions. We have statewide restrictions or closures across the board in West Virginia. Humboldt County, Butte County, Orange County, California, Grace Harbor, Washington, Pulaski County, Michigan, shut their needle exchanges. You guys are pretty close to Atlantic City, where there's been a battle about whether that needle exchange is going to close, and then I'm not exactly sure what's happened, but it sounds like the state has stepped in and said they have jurisdiction over whether the needle exchange stays open. So that's the fate of the Atlantic City needle exchange. Is that, but North Carolina is having a similar battle. So this is happening all around the country. Scott County, in the middle of the pandemic, the county commissioners in Scott County decided to close the needle exchange. All we did to describe that outbreak, all Brandon Marshall, all that swirling of discussion in the journal, JAMA, all these health publications, public health implications, came to naught because the syringe exchange shut down. Will Cook was the only doctor on the ground in Austin. And I wrote a piece for Stat News saying, closing in Indiana syringe exchange would be a public health disaster, but of course it would. You know, it's coming from me. You know what I'm going to say. But the most interesting thing here is this guy. Jerome Adams emerges just as the Surgeon General under President Trump. He goes to Scott County and he pleads with the commissioners not to shut that needle exchange. Syringe exchange programs and medication-assisted therapy work. Will Cook, the doctor on the ground, saying, "Thank you for your support of public health." This is the same man that said in 2016, "You people from outside Indiana don't know what you're talking about." You know, the wildest thing is that I was on a conference call with him and the people who run the Orange County syringe exchange. We're both talking about how we can help them together deal with the closure of the Orange County. But, you know, what happened in Scott County is a tragedy. What happened in all these other places is a tragedy. But it's interesting to think that you have an ally who wants it on the complete opposite side of this question. And so the strange case of Dr. Jerome Adams is something that's going to live with me for quite a while, because he's become a champion for needle exchange. He's actually been pretty good on COVID lately too, which is remarkable. And the final thing I want to mention is I sat watching the Scott County commissioners talk about the needle exchange and the closure, like, you know, dying for them to vote. One of the commissioners waves around this paper. My God, what is he waving around? And it's this paper by Annalisa Packman called "Are Syringe Exchange Programs Helpful or Harmful? New Evidence in the Wake of the Opioid Epidemic." So the case is made in this paper that syringe exchange programs reduce HIV, but they encourage drug use, and the overdose rates go up, emergency admissions for substance use go up, and therefore syringe exchanges are a moral hazard, right? That do more harm than good. We talked about Jerome Adams being an unlikely ally. All of a sudden, we have people within our own field making the case that syringe exchange programs do more harm than good. This is an ongoing running debate between this research group and everybody in harm reduction, basically. These are health economists, analysts, health economists, Jennifer Doliak's health economist at Texas A&M. We said naloxone, the drug to prevent overdose deaths, is a moral hazard. That, well, it may save your life, it's going to increase overall overdose rates and opioid use. And so we should think of both naloxone and needle exchange as moral hazards. Both these papers have been roundly criticized by people in harm reduction, but more importantly, by people who do work in causal inference and quite experimental methods. So you may think, why did you do a mathematical model? Why do you care about the intricacies of this paper? Right? Because it's not just about the issues and the politics of it. It's about being able to meet people on the methodological terms and say, this is why this paper doesn't work. This is why you can see our paper out in the open, but what we did, how we did it, and you can argue it in detail. And so when you think about the future of public health, some of it's advocacy and fighting for needle exchange and what's right, but some of it's doing the hard work to figure out what happened, how to make it not happen again, and do it with tools that are as unassailable as you can make them, right? And that's why we took a simple model, tried to tell a simple story, but grounded in some real hard truths that happened on the ground in Austin, and Scott County, in Indiana over the last decade. So this was done, this initial work, and my lab now works on basically drugs and bugs all the time, substance and infectious disease complications. Forrest Crawford was on my dissertation committee, and we did this work together, which is in this paper in the Lancet HIV. Ellsworth and Bill Switzer, the people with the incidence curve graph, who said, don't borrow that data from our graph. But they were really, really helpful to us. They really wanted to give us the data, but they couldn't. Joan was at the Fairbanks School of Public Health, but I think she's now in Colorado. Also somebody within the Indiana state government who was super helpful to us. People at Yale, my funding from the National Institute of Drug Abuse, and some others from grants that go into Stanford, different healthcare at Yale. And Forrest had a EP1 several years ago when he did this. And here's our shiny app if you want to go play with our model and see the guts and what assumptions we built into it and build in your own new ones. This is my lab, Tommy, Haidam, Julia Boyd, and Sasha. And what we do is a lot of what you see here. And we're about to put in a paper that talks about what happened in West Virginia. They shut their needle exchanges. The HIV infections go up. They shut the needle exchanges. I won't tell you this. I won't tell you the punchline. But what's important is trying to find the data to prove it in a way that wasn't lazy, right? That you'd be hard pressed to say that this was just sort of a fleet or didn't have any grounding in some sort of harder truth with a set of counterfactuals and robustness checks that make sense to us. So this is what my lab does now. And then that's the
Thank you, Greg. I want to first encourage anyone online who wants to put in a question to the Q&A to type in their question. We can start with one question that's already been submitted, and then we'll go around the room and get more questions. So this is perhaps not an unexpected question, Greg, but it asks if we're seeing a repeat of the Scott County case in terms of the COVID situation in the US. And failing to implement effective practices and follow through.
So this has nothing to do with my presentation. So it's just that I have opinions. And so I think there's a public health nihilism going around that we can't do it. We can't do it. It's not worth it, right? And it's fine to let the people in Austin, Indiana get infected, in Lawrence, Lowell, Massachusetts, in Seattle, and Miami. You know, they're not worth it, right? And we already do too much. And why bother? With COVID, 390 people died yesterday, right? In 10 days, that's a 9/11, right? So all during the summer, we had a 9/11 worth of deaths. We're doing all we can, or is it simply not worth it to do more? So I don't know, Arthur, Frank. I would sort of agree that we're in a situation where we don't think of doing what we can with available resources, take it to the sort of stop that epidemic in its tracks, stop that outbreak in its tracks. There's an article today in Roll Call on monkeypox. The federal government decided it's endemic. It's 5 months. Since monkeypox rolled into the US, we're saying it's going to be here for the long, right? In May, we were told we have the tools, we could have stopped this outbreak. We're going to stop this outbreak in track. This is not COVID. So this whole sort of sense of defeatism and nihilism in the context of public health is a challenge for all of us in this field to sort of do better, right? To say we can do better than what our public health leaders, which are not necessarily the people in this room, tell us we should settle. So that's my big opinion, not based on data.
Great. Questions?
I have a data-related question. You said that it's you've had some challenges finding, I want to say good data, but reliable data and data sources for a lot of the parameters that you wanted to have in your model. What are some things that we can do to shore up data in the public health data pipeline?
So I was trained as a modeler, like to make things that you could just put into simulation and they didn't have to represent high fidelity. And in their crude approximations, they could offer some policy advice. I got dissatisfied with that. It's like, it's really important to me to like have model-based analyses, but then to follow it up with empirical work. But I work on drug use, and it's very hard to find data on overdose, fatal, non-fatal. The data is out there on infected endocarditis, skin and soft tissue infections, all the things I care about. The data is out there, you just cannot simply get it. But I spend at least a third of my life talking to state health departments saying, please. All we want is aggregated monthly data. You can suppress the counts, for HIV and HCV if you want. It's like pulling teeth. And so trying to do the study that we did in Scott County, we're lucky we could find that data to do it. And then people like Brandon will do a model-based analysis, which it has a lot of other sort of bells and whistles, but he has to borrow from other sources. We're trying to sort of queue as close to the available data as possible. The study will put out in probably in a couple of weeks in preprint on the West Virginia shutdown with publicly available HIV data. But now we like emergency room data on overdose and substance use admissions and overdoses, with the PACM paper said, sure, it changes reduce HIV infection, but they increase overdoses and emergency room admissions. So we want to try to get that data, but it's impossible. You have to pay HCUP a lot of money. You can buy it for a lot of money. Sometimes you have to beg state institutions to do it. So this is a conversation that has happened at a higher pay grade than any of us. The nice thing is Massachusetts has this section 55. They've collated all their data on substance use and related infections and all in this one data warehouse. And it's amazing because we've been able to do a lot with that data to answer other questions that we don't show you here. So it would be interesting if states on the state level were able to sort of say, like, we're going to agglomerate all our data across the board in a single data warehouse that's open to researchers based on request. But it had to be done under a new statute in Massachusetts. But if you want to do empirical work on vulnerable populations, it's going to be very, very difficult to get that data to do so. And it's not our fault. It's statutory limitations. And it's also the fact that public health departments often don't have the time to go searching for data. Even if like they want to give it to me. During the COVID pandemic, we were like, we tried to stay away because we didn't want to put any more stress on people who were, at their wits' end already from what they had to do already.
I think also oftentimes the data is not even collected.
Yeah,
Testing in COVID in prisons was not existing.
Yeah. That goes without saying. There's certain things you can't even answer the question in an empirical way, but you can't get the data at all.
Other questions?
So I know that in the White House's Ending the HIV Epidemic Plan, Biden names syringe exchange as a policy initiative. So there is national political will, but what kind of harm do papers like the one that you mentioned about moral hazards of syringe exchange, what kind of harm do those papers and like local health leaders like the ones we saw in Indiana, what harm do those have on legitimizing national policies like finance?
So look, the White House has been actually out there and said like harm reduction is part of our national drug strategy. It's like a big thing. But the rubber meets the road in public health at the local and state level. And like decisions to close the Atlantic City syringe exchange were going to happen in Atlantic City, and then the governor of New Jersey said, wait, the state should make these decisions. So that seems to be up in the air. So you're dealing with these battles, you're doing these running battles at the city, state, and county level about things like needle exchange. Right? There are things on the federal level we can think about changing, like access to methadone, which is now in specialized. You have to go to a specialized center to get it. You should be able to get it in primary care. But those are things that can happen on a federal level, but you need to pass a law. So there's lots of sort of structural impediments to harm reduction. They're local, state, county, and then there are ones that sort of you could think about addressing on a federal level.
Does Scott County have a local health department? And what is their reaction to being in the tornado of all this, controversy?
I don't know the health department people. They do have a health department. It's tiny. It's like 2 people. Right? Well, remember, William Cook, single doctor, one doctor in a giant, a huge outbreak in this. So we're dealing with a health desert in many ways. I think the picture, the part of the presentation that's most interesting to me is not my work, but like this whole description of what was going on in Southern Indiana for decades. Terrible company. Just an evacuation of resources from Planned Parenthood to everybody else. And so I don't know what the health department thinks, but they were in the midst of it. Most of the people in Scott County understood that the needle exchange and all the other services that sort of arrived in the wake of the outbreak were a good thing. If you listen to the commissioner's hearings, person after person got up and said, I was against this, but my son, I was against this, but my sister, all this testimony from people all around that region, and the county commissioners were no, No.
I have another question. I noticed on your curve that when the public health emergency was declared, there was a drop down in the number of cases, and then finally, when they did the syringe exchange, it actually dropped even further. But I think you asked the question earlier, and how we haven't studied whether public health education could have been very effective. And it seems from that curve at least, that just the announcement of the emergency itself and the public health education campaign probably had some important effect at that point.
Yeah, but you know, you're a tiny town, so southeastern Indiana. Also, one morning, like the CDC is swarming over your entire tiny town. It might give you an idea that, like, if I'm gonna disrupt it, easily disrupts social and sexual networks, injection networks. We have data to figure it out. So we wanted to say, like, with the thing that you could see, which was the number of people they diagnosed, you just move that in time back, 2013, 2011, you could have done a whole lot differently. But if you added education, if you added buprenorphine and methadone, if you added prevention education, a whole bunch of things, you could have been reduced it more. So we just went with the most conservative, low-bound approach to saying what would have happened if you just acted a little bit earlier and picked up on the signals that were already in your midst.
You know, at the start of the COVID pandemic, there were a lot of people that, you know, thought it might be SARS and not a big deal. And it seems like with any outbreak, there's going to be this tension between saying we need to act, you know, immediately in a huge response versus like, well, let's see how bad this gets. So in this outbreak, you know, how do you convince the authorities that no, you're only seeing a handful of cases, but this is the time to intervene?
Well, the example of that is monkeypox, because now it's not Mike Pence and Jerome Adams, right? It's all the people we know who we've worked on public health with for years. Rochelle Walensky is a co-author who's director of the CDC. Monkeypox comes, they say, we've got a handle on it. We're gonna get it under control. They're like, where are the tests? Where are the vaccines? Then you get a New York Times report in June or the end of June, beginning of July, that they're sitting on 300,000 doses of the GS monkeypox vaccine because they were worried that we'd be depleting our smallpox defense. Like, they're taking a wait and see attitude to this emerging outbreak, right? So even when your friends are in charge, they were waiting to see what happened. We did monkeypox outbreak among MSM in the United States. And then 2 months later, they decided, it's endemic, sorry, we'll try to do what we can, but you're now in the same boat we were with HIV after 1996. We're like, we tried, we did our best, but it's still not.
Great, I think we have time for half of the questions. So if someone has a last urgent question, we'll do that.
Something new came up in that queue.
Okay.
More volume to speak would be great.
That was. I think we're.
Marianne's good for us.
Yeah, there's a comment, I guess, not a question.
Yeah.
Great. Well, everyone, join me in thanks.